then we can get to the good part. I'm going to just do a quick intro of NIMAC for anybody that's not super familiar with us, and then we will bring in our featured speaker in just a minute. So for people that don't know, NIMAC is the New York Mid-Atlantic Caribbean Regional Genetics Network, and we are supported by a federal grant from HRSA. We are one of 7 of these regional networks, so every state and territory should be covered by one of our RGNs, for the most part, maybe not all the territories. So our 10 jurisdictions are listed here in the middle. We just became the RGN for Puerto Rico and the Virgin Islands about a year ago. So our work there is pretty new, but exciting. And overall, we're working to make sure that families in our region have access to quality care when they need it. This is our flyer, which sort of outlines in a basic way who we are and what we're doing. We do a lot of work around telehealth. That's certainly something we want everyone here today to know, that we're here to support your telehealth efforts. So please reach out to us about the opportunities that we have. We also have teams in each of our jurisdictions where we work to understand local barriers to genetic services. And then we also encourage people to use our educational opportunities, including our website and our annual meeting, which I will share more specifically on another slide. As I mentioned before, we do a lot of work in telehealth. So we've provided technical assistance to over 150 of our genetics providers now to help them set up their programs. And we've provided specific training to over 80 students and providers. We have funded 10 telegenetics programs, and through our supported sites have seen over 20,000 telegenetics patients. And we are starting to look at Puerto Rico and the Virgin Islands and what telehealth might look like for genetics there kind of as we speak. We will be offering training again this year. We do this in collaboration with our colleagues in the Western states. It does offer CEUs. So if people are on and are interested in telegenetics training, and CEUs tied to that is a fully virtual program. And my email is here on the slide, so just reach out to me if you have any interest in training. And then we also wanted to make sure people know about our annual meetings. There's always telehealth content there, as well as lots of other great content. This year, it'll be April 5th and 6th. And on the other side of the slide is the flyer from our meeting that was in May 6 months ago. And the recordings from that meeting are now available for CME and very shortly for CEU. So you can check our events page on our website for more information to see the recordings from last year and make sure you're putting our meeting for this year in your calendar. So we encourage you guys today who are with us to make sure you're engaging with us, whether that's through a funded collaboration, using our website, or educational events, attending the meeting, using telegenetics training, joining a team, being on the advisory committee, or we have lots of students that work with us. We look forward to working with you. Our website and emails are down in the corner there. So that is NIMAC in a nutshell. And I'm going to pass it off now to Dr. Bodertha to introduce our speaker.
Much, Alyssa. I'm Joanne Bodertha, a medical geneticist here at Johns Hopkins, and Helen, I'm privileged to introduce today. Dr. Helen Hughes is the Associate Medical Director of the Johns Hopkins Medicine's Office of Telemedicine, Medical Director of Pediatric Telemedicine at the Children's Center, and Assistant Professor of Pediatrics. She is Hopkins Blue, or Blue Jay, I guess, and not only went to med school here, got a master's in public health, and I've been privileged to work with her for I think most of the time I've been here. She was chief resident, I think, when I arrived, and she was editor of the Harriet Lane Handbook. And really, it's just great when sort of colleagues can cross that. And I was very impressed when I heard about her talk and was able to listen to the million visits later, and she's tailored that for us today. So I'm really looking forward to it, and I'm glad to have you here, Helen. Thank you.
Great. Thanks so much, Joanne. I appreciate the opportunity. I'm gonna share my slides. Is that looking okay?
Good.
Excellent. All right. So as sort of a welcome activity, I was hoping that people could chat in their location, their role, and their favorite thing about telemedicine. So I have here, I'm in Maryland. I'm a physician and I like seeing patients in their home setting. So I won't stay too long on this. just enough for people to understand the welcome activity, but then I'll go into the next slides, but it'd be great to kind of see where people are coming from. So the takeaways from this talk, the key lessons learned, I was going to give them at the beginning, at the end, to have a sense of where we're going. So the first is that, change is possible. And I know the NIMAC group has been a proponent of telemedicine before the COVID pandemic, but it's been pretty amazing to see how much things changed at our institution, which was a pretty slow moving institution pre-pandemic. But that there are unintended downstream effects of such rapid change that we're seeing with and grappling here. That patients and providers in general like the option of telemedicine, but that telemedicine is likely here to stay, but the future is a bit uncertain. So this is the story of telemedicine at Hopkins. This is a volume graph showing pre-COVID volumes on the left here and COVID volumes on the right. Blue is video and orange is telephone. Pre-COVID across our entire health system, so that's 6 hospitals and multiple outpatient centers across Maryland, the District of Columbia, I think maybe one in Virginia and some in Florida. We only had 539 telemedicine visits pre-COVID. So this was really just a pilot enterprise of champion clinicians like Dr. Berdertha. Often it was just physicians who were allowed to do it, and sometimes advanced practice providers. And it was hard for people to get going without ease of regulatory reimbursement and other issues. But we saw a pretty exponential explosion at the beginning of the pandemic, which has persisted to some extent, where we've had over, as of today, I think 1.1 million telemedicine visits. This is comparing our telemedicine volume to our in-person outpatient volume in orange. So you can see on the left a steep decline quickly in the outpatient volume in person at the beginning of the pandemic. With an increase in telemedicine, we got to about 50 to 60% of all of our outpatient care was telemedicine at the beginning. Then we saw in-person volume kind of go slowly back up, and we've maintained about 20% of our outpatient volume as telemedicine. Of note, basically, we've had this slow return to about 100% in-person volumes, but we've felt that so far the care has been substantive as telemedicine. We haven't gone to 120% of our pre-COVID volumes. Kind of our healthcare ability to deliver care is a little bit fixed. So telemedicine has been an access point, but hasn't necessarily added additional care. So thanks to those of you who have chatted. Hello. So the next question would be that you could enter in the chat. In your practice, what % of all genetics visits have been by telemedicine since March of 2020? So you could just throw in a % guesstimate there. No right or wrong answers. If you think it's, most, little bit, 90%, excellent, 100%, 25%. GC practice, 99%, 100%. Okay, interesting. So we're seeing a lot of people who've been doing almost all telemedicine since the pandemic started. And some people have pretty wide variation, so 25%, 5%. Thank you. So we, across our health system, have seen that it's definitely not a one-size-fits-all solution. If you take just telemedicine in sensitive areas, so that excludes things like lab and radiology, which usually have to be in person. In the last quarter, about 21% of our care has been by telemedicine, but it really differs a lot by specialty. So you can see psychiatry all the way on the left. They had been at a peak of 86% of visits by telemedicine and are now at 79%. Nutrition, neurology, and then we have our genetics department at number 4. They were up to 61% at the beginning, now at 42%. I think the cross-state licensure changes, which I'll talk about a little bit later, have really impacted their ability to see the wide catchment area of patients that they have. All the way down to orthopedic surgery and ophthalmology doing almost nothing throughout the pandemic. So that's been interesting to kind of see, just in a natural way, what specialties have felt like this has been a better part of their practice to incorporate, and other specialties haven't found it to be that way. So what are some of the downstream effects that we've experienced from this rapid transformation been? So at least at this moment, still about 18 months in the pandemic, our patient care modality choice is still relatively haphazard. So we don't have any clinical decision support or kind of top-down information about what sort of care should or would ideally be by telemedicine versus in person. It's really a patchwork of patient preference, provider preference, or divisional or departmental preference, schedule template availability. And we feel like we have limited research, even though we've had these 1.1 million visits, limited research to understand kind of how to guide people about what type of care should be by what modality. We've had pretty limited ability to address patient needs. I've been interested in telemedicine even pre the pandemic as an access point, and really appreciate the mission of NIMAC and the HRSA programs that have tried to increase access through telemedicine. But, with fewer than 600 visits pre-COVID, we certainly did not have a robust plan for implementing telemedicine in a way that was accessible for all patients. So we haven't yet had time to figure out device access issues, internet access issues, patient concerns around trust of the modality or privacy, and tech and health literacy and familiarity with it among different populations. And we've had a limited ability to address provider needs. We have done some amount of training and education, but we're still working really hard around staffing and support workflows, and haven't found magical ways to make it easy to find ways to staff the telemedicine visits above and beyond in-person visits, and making our workflows easy for providers and for patients. We have done some early work to try to understand maybe what are the patient populations that are having more difficulty accessing our telemedicine-based services. We have a telemedicine equity dashboard that looks at % of visits delivered by phone as an initial measure of disparities, as we feel like our video-based services are the more ideal way to have a visit where you can both see and talk to your provider. Of our almost 1.1 million visits to date, at the top left, you can see 18% have been by telephone, but there's a different amount of telephone use and need for telephone visits in different populations. You can see the gray bars are % of visits by telephone, the blue bars are % of visits by video, and on the right is the N of that population. So we have higher telephone visit rates among patients identifying as Black or African American or American Indian Native Alaska Native, higher rates in those who have preferred language of Spanish and other non-English languages, higher rates of telephone use among older populations. You can see here 75 plus has 29% telephone use, whereas 9% of privately insured patients have had telephone visits, or 9% of visits among privately insured patients have been by telephone. We have 23% and 28% among public payers, Medicaid and Medicare. And then by geography, there was potentially a narrative before the pandemic that broadband internet access and tech access was predominantly a rural health issue. Certainly, it still remains a rural health issue. But from an urban health standpoint, we see this butterfly pattern of East and West Baltimore, which this map links to another, or if you overlaid it, follows a number of other socioeconomic measures. But in blue, dark blue is 0% telephone, dark orange is 50% telephone. We see high rates of telephone use in East and West Baltimore. And that maps to also the broadband availability of access in those neighborhoods. It's even more distinct in the older population. So if you look in the neighborhood next to Johns Hopkins, zip code 21205, among patients over 65, 58% of their telemedicine visits have been by telephone. When we look at our genetics here at Hopkins, it's actually not too bad from a telephone standpoint, probably because a lot of these patients have been younger, but we've seen that most groups have been able to participate in video-based telemedicine care, but patients who are not English speaking would be the area where I think that has been the most difficult. And we do not have a simple, robust interpreter integration system yet. We're working very hard with our telemedicine vendor, but it's certainly been a challenge. I'll do one more slide and then I can pause for any questions about this. One early step we've made, we have not at all solved any of these problems, but we did recently describe a process we have, a video technical risk score tool that we have in our Epic electronic health record system. You can see here in the bottom right, where basically we've identified some preliminary factors we think highlight a patient might have more tech difficulty with their telemedicine visit, including not being active on MyChart, which is our electronic health record portal, not having done the electronic check-in process before their visit, not having had a video visit in the past 3 months or doing a telephone visit in the past 3 months. And so we have a column that can be added to any scheduler, support staff member, or provider schedule, where they can see on a green, yellow, red score how ready the patient might be for their visit. That's helped us stop calling patients who are green and likely have done this before successfully and may not need extra support, and call more and outreach more to the patients who are red and might need additional support. Any questions from the audience regarding that piece? Going to transition to another topic next. Okay, so overall, we found that our patients and providers have really liked having this care modality. If you look at our Press Ganey surveys, tens of thousands of surveys, we've had a 95/100 rating with accessing JHM providers over telemedicine. When we asked a virtual advisors group of about 700 patients, median response of 9 out of 10 would recommend our telemedicine services to friends and family, and 88% said it would be at least moderately important to have video visit options after the pandemic. Before I transition into showing a few results from a provider survey we did, I was wondering if people could chat how often they feel they can provide clinically appropriate, high quality care in their field, which for you guys would be genetics, in comparison to in-person visits for new patients and then for established. If you could maybe chat percentages for new and established, how often you feel you can provide clinically appropriate, high quality care via telemedicine for a typical patient in your specialty. Okay, this seems like it might be a harder question to answer. So feels like it's expanding, changing over time. Readiness score could be impact. Okay, working separately from a geneticist, feel like often could provide high quality care since not needing an exam. That's really helpful. And how about what percentage of your scheduled template would you like to have open for telemedicine? So if you're a provider, whether you're a genetic counselor, geneticist, or other type of provider, in your ideal state, depending on how much you like to practice, how much of your schedule would be open for telemedicine visits? It's 25%, 50%, 25%, 100%. Excellent. So great to see a range there. So we did a survey of our almost 4,000 providers who completed telemedicine visits in the last, we did the survey 4 months ago, but the year before that. And after 2 weeks, we had about a 37.5% response rate. So we got 1,300 responses. We were really impressed with that response rate. We asked, how often do you feel you can provide clinically appropriate, high quality care via telemedicine in comparison to in-person visits? We had a mean of 41% of the time for new patients and 60% of the time in established patients. And we saw those numbers were higher in genetics. We only had 12 people from the Department of Genetics complete the survey. Half were genetic counselors and half were physicians. But we had a mean of 58% for new patients and 70% for established patients. So it looks like we're getting a lot of 100%, and potentially some of those are from the genetic counseling group. So it sounds like some of you are finding in your practice that it could be a really powerful tool and a way you prefer to offer care. When we ask what percentage of your scheduled template would you like to have open for telemedicine among our providers, then we had a mean of 40%, and among genetics it was 57%. But the variability was pretty impressive. We made these box plots to try to understand the numbers, and pretty much in every specialty, there's a median and there's a mean, but there's someone who says 0% and there's someone that says 100%, and there's a fair amount of variability in between. So I think there are so many factors that go into if providers are comfortable providing a lot of telemedicine or not, and it's going to be really interesting to see how things kind of even out over time. We did ask some questions around on the left, assuming if you had the necessary equipment, where would you prefer to do most of your telemedicines? And most of our providers are saying at home. We also asked if people like to do mixed sessions like telemedicine in person versus telemedicine dedicated, and most said dedicated telemedicine only sessions. We also asked some questions about after hours and weekend care and found that most people did not want to provide after hours and weekend care, but maybe a quarter to 40% of people were willing to provide after hours or weekend care, but much more likely if it was by telemedicine. So, I think certainly we're hearing a lot about the work-life flexibility and childcare responsibilities and other barriers that families face, but it was interesting to hear in this some of the, maybe barriers that physicians face to, needing to be home with their families or are wanting to be home more quickly in the evenings, and that doing a telemedicine session where when you're done at 7 p.m., you're home because you're already home versus being done at 7 p.m. in clinic and then having to drive home was potentially more enticing to patients, and I think could be an interesting way to improve access after hours. When we asked about barriers, certainly we're seeing internet connection issues and some video and audio connection issues in our platform being a barrier. Providers also said that patients not having access to our electronic portal is a barrier, although we've developed systems for texting out the link outside of our portal because we do not actually want this to be a barrier. We want patients to be able to participate whether or not they have electronic portal access. Some providers are finding that patients prefer telephone or other video technologies outside of the one that we use as a system. So next, I just wanted to talk a little bit about the regulatory environment, and then we'll have plenty of time for question and answer. But I'm not sure how many of you were doing telemedicine pre-COVID. Alyssa, would you say it's most?
I wouldn't say most. I would say, because of the audience that comes to this call, maybe it's most on this call, but I think we were seeing more like between 20 and 40% of the genetics providers in the region were doing something before the pandemic.
Okay. So you guys are probably a trailblazing group, and some of you may be aware of this from your pre-COVID work, but there were so many barriers to doing telemedicine, particularly with peds patients before the pediatric age patients before the pandemic. And Dr. Berth has been a trailblazer at our institution and had a program before the pandemic, and I was leading a small peds specialty follow-up program. And because Maryland Medicaid, like a lot of other states' Medicaid programs, required patients to be at specific sites, not their home, before the pandemic, we had this program where patients could go to a health department on the Eastern Shore for their follow-up visit. That would save them a 2.5-hour drive. The specialists would be here at Hopkins. But we just found that just getting them to the health department was also a barrier, and triangulating the health department's availability, having a telepresenter, having our specialist was also a barrier. So it was really interesting to see all these regulations change. But just to overview those who aren't familiar, the pre-pandemic regulations that were barriers included regulations around patient location. So most private insurance companies actually did cover telemedicine when patients were in their homes pre-COVID. But because of the other rules I'm going to mention, it usually wasn't feasible to offer one type of care to privately insured patients if most of your insured patients were not in that bucket. So most state Medicaid programs, including Maryland, required patients to be at certain originating sites pre-COVID. That was not true for California Medicaid, I believe. They allowed home to be an originating site before the pandemic, and so they had a much robust telemedicine program. Medicare required patients to be also at certain originating sites, not home, and also to be in health professional shortage areas. So there was a more emphasis on rural health for the Medicare population. There were also regulations around provider location. So Medicare and most state Medicaid programs required that providers be at certain distance sites like a clinic. And then there were provider type and licensure issues, which you all may understand way better than I do, not being a genetic counselor, but that not all provider types were allowed by payers or by states or by licensure boards to do telehealth. I think in Maryland, it was mostly physicians and advanced practice providers, and that practice of medicine or profession was generally dictated by where and is still dictated by where the patient was at the time of care. So you needed to be licensed if you required a license in the state to see a patient who's physically located in that state at the time of the visit. And then there were technology and platform issues that telemedicine was defined only as two-way audio visual, so you had to see and hear the patient, and that most regulations required certain HIPAA compliance around platforms. So what happened in the pandemic for patient location, Medicare and Medicaid put waivers in place that said telemedicine could be done and billed when the patients were in their homes, and also providers didn't necessarily to be at a specific site, they could be at their homes. Provider type and licensure, much more broad types of providers could participate, and most states put into place waivers that allowed physicians or providers licensed in other states to see patients in their states. And then technologically, telehealth was now also defined as audio only care, when you could just talk to the patient, for instance, over the telephone, not just see and hear them. And the Department of Health and Human Services put in a HIPAA non-enforcement waiver, meaning that you could use FaceTime if that was the platform desired by your patient, without any worry that you would be prosecuted for HIPAA violations. So our office has tried to do some advocacy around helping to make sure some of the waivers and changes that have been put in place stay longer term. We presented information to the Maryland legislature, which passed the Preserved Health Access Act of 2021, which just went into effect this July. So Maryland has decided to remove those patient and provider site restrictions for any health plan regulated by the state of Maryland, which includes Maryland Medicaid, to have video visit parity, so reimbursed at the same rate for Medicaid coverage, preserve telephone or audio only reimbursement, and remove some home monitoring barriers. So we were really happy to see that passed. It's been passed essentially for 2 years with a plan to have a review or study by the state Maryland Healthcare Commission to understand what should happen after that. So it was basically a 2-year law to keep what's happened during COVID for our state moving forward. However, for the cross-state licensure, most of those changes that were made by the states have since expired, which I'll talk a little bit about more on subsequent slides. Hopkins helped with other institutions to co-sponsor the TREAT Act, which was an act to have national licensure reciprocity for all health professions during a public health emergency and for 180 days afterward. So it would have, had it passed, it would have provided a lot more certainty that there's national licensure reciprocity until 6 months after this is over. But unfortunately that did not pass. And instead we've had this really complicated patchwork of like slow state expirations and trying to navigate which patients from which states have been seen. This was the pre-COVID licensure state on the left that we've talked about a little bit, that the power to license and regulate professions is dictated by the states, and there's really limited federal involvement, and that healthcare professions must be licensed in the state where they're located. As I mentioned, all the waivers went into place in March and April of 2020, and these waivers varied a lot state by state by whether it covered new versus established patients, what type of providers were included, whether patients could be inpatients or outpatients, and when they expired, which has actually been hard for us to figure out. Some were tied to the federal PHE, some were tied to state PHEs, some were tied to federal PHEs, and then they changed their mind and still canceled them anyway, even though the federal PHE was no longer is still in effect. So it's been a really complicated process to navigate. So as of today, most states, I think all but 3 or 4, have had their licensure waivers expires, generally meaning that if you want to see a patient who's located in a state in which your profession is licensed, and I know this is a complicated issue for genetic counselors, which I'm not an expert in, so I'll speak a little bit to the physician side, but that you generally must be licensed in the state in which the patient's located at the time of care. But there are some interesting exceptions, and it's worth exploring these. For instance, Florida has a really brief telehealth provider license that is like $50 and just takes a day or 2 turnaround. You basically complete a relatively brief online application. Arizona passed a new state law in May that they're basically going to recognize any other state's license. You're just going to have to go through a process to get registered with the state of Arizona, but there's no process yet to do that. So that should happen. It just, there's no operational way to make that happen yet. And for Maine, there's a limited teleconsultation license for specialists. So this could be worth looking into, where if you're going to provide consultative services to primary care doctors in the state of Maine, you can have a limited telehealth license to do so. Our approach to scheduling has been that pre-COVID, at the beginning of the pandemic for about the first 10 months, we had some scheduling logic in our system that asked to the department, is this a reason for a visit that's okay for telemedicine? If the patient wanted telemedicine, we used their home address and compared that to the state waivers to understand if they could be scheduled. Now we're actually asking a scheduling question of all patients who want telemedicine. Where do they intend to be at the time of their visit? Because that could be their home state or a different state. And then based on that intended location state is where we compare it to any waivers that exist and the provider's licensure and decide if the patient can be scheduled. So in terms of the future state, from my viewpoint, what the future state will depend on is what happens with private insurance companies, which is sort of the least questionable thing. I think private insurance companies in general have embraced telehealth to the point of also including telehealth services in their own offerings, virtual on-demand care offered by health plans. But really pre-COVID, a lot of this was covered by private insurance companies, at least when we talk about outpatient video visits. It'll depend on what happens with the states. So whether each state decides to define telehealth as two-way audiovisual or audio only, how state Medicaid programs are reimbursing, and how state Medicaid programs determine patient provider location, provider type, and what states decide around licensure rules. And then federally, and this is interesting to me because before I took this role in the Office of Telemedicine that is more of a health system role, I had very limited visibility into Medicare because I took care of no Medicare patients. But for most health systems, Medicare is the primary or the largest insurer. And so what happens with Medicare at the federal level matters a lot for all patients, because if the largest insurer doesn't cover something, it's hard for health systems to operationally offer it because they can really only offer things that they can offer to most of their patients. So we'll have to see what the federal government decides the definition of telehealth should be. Should it include audio only or telephone care? How will Medicare reimburse? Will patient or provider location go back to the pre-COVID state or stay its current state? What types of provider types can be covered, and then does the federal government want to have any role in cross-state licensure reciprocity? And a lot of this is not in CMS's control, it's in the Congress's control, so it would have to be new legislation that would make these changes, and everyone's very worried about the budget for Medicare and not wanting to increase costs. So it will be really interesting to see what happens moving forward, but definitely an area for advocacy. I'll just end on some resources and then happy to leave plenty of time for questions and discussions. I find that the Center for Connected Healthcare Policy, their website URL is at the bottom, has really great, well collated information. Still, there can be holes here. And so, linking with regional and local, professional licensing boards is also can be really helpful, but they have topics, general topics like definitions, specific resources related to COVID-19 on the left. They have state-based resources. So if you go to the state of Maryland, you can see, what is the definition of telehealth in the state of Maryland, consent requirements, out-of-state providers, et cetera. So this is definitely one of the best resources I've found. So to summarize, it's been amazing to see what change is possible, but also to see some of the unintended downstream effects of this rapid change. We feel that our patients and providers are really liking the option of telemedicine, and we think it's here to stay, but we're a little nervous that the future, particularly related to Medicare, the cross-state licensure is unsure. And we'll be happy to, I think the field of genetics has a lot of ability to advocate serving patients who have rare conditions. I think those patients who have rare conditions really have a lot to gain from having access to specialists across state lines. And the VA as an underserved group has a law to have federal licensure reciprocity. So I think patient organizations and advocacy organizations around helping patients with rare conditions get cross-state care is really important.
Thank you so much for all of that wonderful information. I know most of the people we have on the call today, I think everybody, as I was watching the chat, is doing telehealth also. So I'm sure people have questions about things, barriers that they faced or changes they're trying to make, or as Dr. Hughes mentioned, kind of the adaptations we're trying to figure out now about how to run schedules and block time for telehealth versus in person. So we'd love to hear from anybody that has questions. Either feel free to unmute yourself or put anything in the chat that you would like to share.
I'm going to ask the questions, Joanne, and it may be there are a couple of my colleagues who are on the call and they may know more about this. What have you done, Helen, to operationalize the with administrators or clinic coordinators, whatever, the column for, understanding a little bit better the risk score, because I don't think it's on our schedule, and I take ownership that maybe there's something I should have done, but
Yes.
it doesn't seem to me, I mean, when I have a no-show at a telehealth visit and I go, I mean, essentially the coordinators say, look, they, were contacted by my chart 7 times, but at least the patient, has no evidence that I can find in the chart that, so I'm not saying force field function, but I wondered 2 things. One, it's like any QI sort of thing. It's like we can set something up, but if people don't do it, it's sort of not happened. But then I
Totally.
also wondered if other, people are on this call who are in other systems have developed anything, that's a little more tailored to genetics patients in terms of making sure they're accessible, or has it meant people, again, falling off the map, or either in that phone group or somehow under resource group technologically?
Sounds good. Well, I can try to answer the first question, and then we can go again. Would definitely welcome any recommendations about adding it. It's not a static column that's on everyone's schedules automatically. You have to add it manually to your schedule, which I'm happy to show you how to do. We met with the operations managers, so like different people who manage building operations, clinic operations at different sites. We've met with the nurse managers. I met with the, anyway, we don't have to get too granularly. It's really hard to spread the word about something like this that like requires an extra step. So, and I think since everyone isn't doing telemedicine, it would be hard to get it added to everyone's schedules.
Yeah.
But would certainly love to talk about offline about how to better operationalize it.
Yeah, and again, if there's anybody from our group who has done this on their own schedules or thinks we should try to do it, since we still do a fair amount of telemedicine more broadly, that's sort of a Dana Carolyn discussion, I guess.
Okay.
So then I guess I was interested if other people had done or found other successful mechanisms for, reducing, when we started, obviously, for the Polycom and now WebEx systems, there was an enormous, like, you kind of went down the tree of the Russian dolls of starting with this and then trying this and then trying this and then getting your cell phone out and having everything positioned around. And I just wondered if other people had other systems they had for, identifying people ahead of time who are going to need additional help.
I was interested in your data about the audio only in terms of just even your mapping of where, we work in a rural area of upstate New York. And what I've noticed is that as much as somebody might want to do a Zoom appointment, their phone capacity, they don't have adequate phones. So they have to do audio only. So it's not just the Wi-Fi capabilities, the phone that they have. So I thought that was very interesting and actually quite helpful in trying to sort of struggle with, why isn't everybody doing telemedicine? It's their phones. They can't do it. And they don't have iPads and don't have computers. So, but thank you for this study. This was very interesting.
Oh, you're very welcome. I was recently chatting with someone from CMS who works for the Office of Minority Health, who is involved in some rural telehealth efforts. And she was showing a little bit of data around just broadband infrastructure, and a lot of rural areas, like literally not having the infrastructure. Like it didn't matter if you were a millionaire, like you could not pay to have internet bandwidth, like in a, have it hardwired into your house where you had wireless internet bandwidth. And we've certainly struggled with our platform working well when people are on like older phones that have cellular data and aren't using like a wireless network. So totally hear what you're saying and agree. And I think that's been a really big piece of advocacy for us around the audio only or telephone telemedicine, because pre-COVID it was defined as two-way audiovisual. I think we'd all love to envision a future state, maybe 10 years from now, when we've had a lot of infrastructure investment to have a lot more internet access. But until then, we feel pretty strongly that audio only is a big kind of lifeline for certain populations to have access. And but others worry appropriately that it could create a two-tiered system. So if you give people audio only access and it's potentially not as good, you're saying it's okay for people, and then what responsibility is on to like a healthcare provider, a health system to fix that issue, which is more of like an infrastructure issue or a socioeconomic or disparities issue. So it's at least interesting discussions.
Yeah.
One of the things that we've seen happen, as you said, kind of short-term solutions where we hope the long-term solution is just going to be universal access. But one of the short-term solutions we've seen, our colleagues in the Western States Network have been really involved with programs with the public libraries offering telehealth. And I was just wandering in with my mask on to my public library a couple of weeks ago, and I saw a big sign up that they're offering telehealth there as well. So they dedicate rooms at the libraries, and they usually have staff members that know enough about kind of how to get the person set up, that they're sort of trying to create, really local spaces that people can go for telehealth appointments that can't do it at home. So it's a cool solution.
Yes, it's really interesting. And then, there are lots of privacy concerns, like, are you okay with being in a library doing your telehealth visit?
Sure.
Maybe there's like but even privacy concerns for patients who have like crowded housing conditions, do you may not feel like you're able to be as private and have as intimate of a discussion with your provider or your genetic counselor if you're in a house where everyone else is around you and hearing it, as opposed to being at a doctor's office.
Yeah.
I was just going to say, this topic came up for us yesterday when thinking about like adolescents and, young adults, and giving them the opportunity to not have their parents in the room, but like, how do you actually make that happen when they could just like move out of the screen?
Yes. We've not that it's a high-tech solution, but gone to headphones. So like asking the adolescent or teen to have headphones on when we're having the visit, and then at least they're in control of what they say, and not necessarily having others hear them. But it certainly doesn't feel, honestly, I'm not sure the parents can't sometimes hear what we're talking about when they stand outside of the room, but it certainly feels like you have some amount of control when you're in an exam office.
Yeah. One of the interesting observations I've heard from some of our genetics providers, and I'm just curious to hear if others in the groups have had this experience, is that with the telehealth at home appointments, they feel like they're seeing things. Usually it's pediatrics, and the ways the kids are behaving in the home environment, that's more true to their daily life and is sort of aiding their assessment of the kids' strengths and weaknesses. Something that never occurred to me before, but a couple of our geneticists have said they feel like the kids freeze up a little bit in the clinic, but when they're home and on telehealth, they're kind of more true to what the parents are experiencing on a daily basis.
We found that with neurology as well. They've definitely been one of our like top 5 divisions or departments. And I think for child neurology, they've felt like sometimes they get more accurate assessment of the patient's abilities when they're viewing them in their home environment, like playing in a playroom, for instance.
Yep, exactly.
And then in terms of physical exam, I don't know if anyone feels willing to unmute and talk a little bit about that. We do have some remote physical exam tools that we're trying to early deploy. We have a contract with a company called Tydo that has home devices that patients can have that facilitate exams. We also have a cardiologist who has a pilot research project where he's sending 4G enabled stethoscopes to patients' homes by FedEx and then getting them FedEx back, which has actually worked quite well. So I just wonder if anyone has experience with any remote physical exam tools and or feels like that would be helpful at all, or if just like the in-person exam is so important.
Yeah, I'll speak. I think it's hard. You can only get the kit, like when we're looking, say, in a child with deafness, hard of hearing for heterochromia. They even if they're able with an interpreter, doing sign language, et cetera, to get them at the right distance from the camera so I can really see their eye. It's just an odd thing. And lighting, I think, can be an issue. And so much of what we do in genetics, again, is measurement. You try to make it sort of playful and everything else. Some of the telehealth I did previously on the Indian reservation was as a general pediatrician. And again, maybe I was just younger. I was younger, but to the extent that my satisfaction with my practice, it was okay because I wasn't measuring as much. But head circumference is one of my pet things, and that's I occasionally will ask parents if they have a tape measure, and we'll see if they can measure the head. But since that's omitted so much as probably talked to you about this, Helen, you know, in pediatric medicine, even neurology sometimes doesn't do it. So I still feel for an initial visit that it's better from the genetics exam to do it in person, and the level of collaboration. And you know, I don't examine genitalia on video. I mean, that's not something we do. And so if that's part of the exam, you know, you can tell kids they're going to the beach or something for taking their shirts off, or, you know, that sort of thing, if for younger children. But I think I have this little nagging thing that I'm not doing my job as well as I should for the exam part. And people send photos, and again, you know, that's the other part. I mean, you may supplement, like the family will say, if they have a phone that can take photos and they're not limited otherwise technology, they'll sometimes say, well, please take a photo of that. Maybe you can give me a better view than we can do with the camera on your computer, or what they're doing right then.
Yeah. And it was mentioned earlier on, but, you know, some of the telehealth that was happening before the pandemic, or even a lot of it, the families weren't at home. They were in some other clinical setting. So Joanne's been talking about some of the telehealth she did, and some of that was happening at a federally qualified health center where theoretically there could be a supporting clinician on the other end. So that's sort of a different, you know, different types of telehealth really have different issues when it comes to whether someone's there to help with a physical exam, and like what, you know, it's like different tiers of data you can get depending on what the site is that the family is in when you're talking to them.
I don't know.
One other thing, oh,
Go ahead, Gretchen.
I was just thinking about, and it's not really physical exam related, but just logistics related. The one thing that I found was really a necessity was having two screens, whether it was doing the visit on my phone and having my computer, or having like two screens with my laptop. Because if you didn't have that set up, typing in the computer and trying to flip back and forth to see them, it was just not productive. But really having the two screens to see them and then be able to document was hugely necessary.
Mm-hmm. Yep. One of the other things I hear about a lot, if anyone else has experience with this or solutions, I'd love to hear about it. So one of the things we're seeing a lot is struggling with families that do choose to and consent to have testing at the end of the telehealth appointment, actually following through when you're sending a kit out, or, you know, not doing they're not there with you to draw their blood in the moment. So you're losing a lot of patients that theoretically wanted to have testing. So we've seen some of our sites try different things from, you know, sort of QI perspective, what works to help patients actually follow through with testing. But I'm curious if other people have had any creative solutions or seen the same problem with their practice.
We've certainly seen the same problem, and not just in genetics, but in primary care in particular, where they have these value-based measures for like colonoscopies and breast cancer screening, et cetera, that, you know, the patients aren't getting the mammographies ordered or the colonoscopies ordered or whatever it is, but it's not getting done. And then that strains the clinic staff, because it involves an additional outreach to kind of follow up to the patient. So yeah.
Yeah, as I said, I haven't really heard, other than repeated reminders, I haven't heard anyone come up with concrete solutions to that, other than I do know some places send the kits ahead of the appointment, which is, you know, potentially problematic for other reasons, like the family hasn't actually elected and consented yet. But then if they have the kit, you can do it with them while they're on camera, and they're much more likely to get it done that way. But, you know, that sort of opens the thing about whether you're comfortable shipping a kit ahead of a decision.
But I was going to say, one thing we realized about the kits too is, especially when dealing with some underserved populations, like they don't have experience with FedEx. And so being able to just like, oh, and then you go to a FedEx place or bring it to your work and you just drop it off, like that has been a big barrier. And so once we realized that, we're like, oh, we either need to like have a different mechanism for them to get the kit back, or do some different education, or have, and yeah, that was a big realization for us that we just kind of made, which is sad.
Yeah, no, that's a really important one. And I think for most of us that have kind of used those kits before, at least my first experience with opening one up and really like trying to, from the patient's perspective, understand what the instructions say. And it's pretty complicated. Like there are oftentimes 2 or 3 different little cards that are telling you what to do, and they're not exactly the same from one to the next. And so I understand how people kind of open the box, get overwhelmed, and put it over there until, sometimes till forever, and it never gets picked up again.
Yeah, I mean, it's interesting to me, like area under the curve at a population level, you guys are probably reaching more patients than maybe you've ever have before if there's like this explosion in telehealth, and maybe you have lower no-show rates. And so like you're actually talking to more patients, but maybe you're doing less testing. And so like, where's the area under the curve benefit? Because it could, be higher benefit to be touching base with more patients, even if you're doing less testing, but it's hard to know.
Yeah. Definitely. And I think we had a special interest in looking at no-shows kind of 5 years ago. We were just starting to think about how that was a clinical problem, mostly for in-person care we were focused on. And I don't know sort of if Dr. Hughes, what you've seen, but we saw very early in the pandemic, super high attendance rates with telehealth appointments when people were in lockdown and everyone was home and there weren't a lot of competing priorities. And I think for the most part, people are still feeling like you're getting fewer no-shows with telehealth, but it's not quite as kind of magical as it was at the beginning of the pandemic with everyone showing up for everything.
Yes, that's generally the trend that we've seen. And sorry that I don't have those data, but yes, generally we've seen slightly improved no-show rates like across the board. But I think psychiatry has had very impressive and sustained decrease in their no-show rates, partially, convenience related, partially stigma related, partially frequency of visits, because a lot of people, their psychologists are meeting like weekly. And if you live 2 hours away, it's like just not possible. You're free to come and see them weekly. So that's been very interesting.
Yeah. And I think the point you made early on about the uniqueness of rare disease and access to specialists across state lines is something that not a lot of genetics providers have at the forefront of their mind when they're thinking about the relevance of telehealth to genetics, but it's really important because we've all had those experiences with patients who we really want to see this one person that happens to live in Nebraska or whatever it is. And that used to be so hard to make it happen. And it's so relevant to some of the families we see.
I mean, we have some, like there's a, Joanne, you can probably speak to this more than I have, but I think Hillary Vernon's clinic on Barth syndrome at KKI, I think she sees like most of the patients with Barth syndrome in the United States. And there are like fewer than 200 and they all come to this one clinic. And, if you live in Wyoming and your child has Barth syndrome, you should be able to see her. She's the expert in it. All the other children in the country are seeing her. So it seems to me that if we have waivers, carve out waivers for these populations, like the sports medical licensure compact, that children with rare diseases should be in there as well.
No, and it gets further complicated. This is not Hillary, but Jill Farner, where the patients are so rare. She and Hans Bernsen started the first epigenetic clinic in the United States. That sort of having those patients come from all over is for getting a clinical trial, and also their visit is dependent on sort of the compact, making sure they can travel in the pandemic. Making sure there's something that when they come, because if the clinical trial is approved or the research study is approved, then they can, get their skin biopsies or whatever is needed then. And so the rare diseases or special diseases where the families want to be involved in trials or research, and sort of the timing, again, and then school situations, et cetera. So I think that both the compact and IRB and clinical trials have made this all complicated, but as an option, it's really important.
Yeah. All right. Well, we just hit the hour. So I want to thank Dr. Hughes again for being here with us, and thank you guys for being here. And please reach out to us at NIMAC if you need any support with telehealth or training or education in other ways. So thank you all for joining us, and have a great weekend.
Thank you.
Thank you.
Take care.
Bye-bye.
Thanks. Bye.